Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. Nearly 2.5 million Americans suffer with inflammatory bowel disease, or IBD, like Crohn's disease and ulcerative colitis. Both conditions cause chronic inflammation of the digestive tract, but they can affect different parts of it. The first week of December is Crohn's and Colitis Awareness Week. So yes, we're going to go there. We're talking with WVU Medicine gastroenterologist, Dr. Jennifer Hadam-Veverka, about diagnosing, preventing, and new promising treatments for both of these conditions. Welcome, Dr. Hadam-Veverka, to Live Healthy West Virginia.
Thank you so much for having me here. I'm very excited to talk about this condition, which I'm very passionate about.
And before we get into the questions, I want to point out you're also director of the WVU Medicine, finish it for me.
Inflammatory Bowel Disease Center.
Okay.
Yes.
So you really know what you're talking about.
A little bit.
Okay. So let's start with, first of all, what exactly is Crohn's disease and ulcerative colitis, and what's the difference between the two?
Yes, that's a great question to start it off. So inflammatory bowel disease, the most common conditions are ulcerative colitis and Crohn's. And this is a chronic. There is no cure to date for this disease that causes chronic inflammation in the GI system. So to break it down in simple terms, if you have inflammation or infection, normal person's immune response would be to send out inflammatory cells from the body to the colon to fight this inflammation. Now, there's something in that signal that goes awry in inflammatory bowel disease because the body keeps sending those signals and the inflammation continues in that disease. So different than the normal population. And as you said before, 2.6 million Americans. There's 10 million worldwide. So about 1 in 100 people have this disease, and we know the prevalence is increasing. Now, there are differences between Crohn's and ulcerative colitis. The biggest difference is the location. So ulcerative colitis is inflammation in the mucosal layers of the colon. So it can just be the rectum or proctitis. It could be the left side of the colon, or it can be the entire colon.
Oh, wow.
And it's different from Crohn's, as I call it its cousin. It can be a little trickier because that can be inflammation anywhere from the mouth to the anus. And Crohn's is not continuous. It can have skip lesions. So you can have inflammation up in the stomach or small intestine and in the colon. So differences. And it also has transmural, so it involves inflammation throughout all of the layers. So those are the biggest differences.
Wow. Okay. And you just mentioned that it's increasing.
Yes.
Do we know why it's increasing?
Well, we know that there are several factors that put you at risk for inflammatory bowel disease. We know genetics. So people who have inflammatory bowel disease, anywhere from 5 to 20%, it's higher in Crohn's than ulcerative colitis, have a first-degree family member with inflammatory bowel disease, meaning mother, father, brother, sister, or child. But genetics doesn't play an entire role. There are several factors that combine that can cause a person to develop inflammatory bowel disease. First, we know Western world. So industrialization leads to big changes and big increase in inflammatory bowel disease. I think that's why we're seeing it worldwide. We know diet, the Western diet.
So good for
yeah,
you.
right, yeah. high fat, low fiber, right? We're running through the drive-through. We also know that as countries become more industrialized, our hygiene is better. So maybe not being exposed to the microbes at a younger age, that the immune system can't develop that innate fighting power. Some people theorize that also exposure to medicines or antibiotics when you're young can contribute to that. And smoking can also contribute. So lifestyle plays a big role besides genetics.
So it sounds like it would be more of a problem here in West Virginia.
Yes, definitely. Definitely.
We're number one or up there in all the wrong things. But
we have hope. We have hope.
Yes, we have hope.
Yes.
That's what I like.
Right.
That's what I like. So I know you you just talked about this a little bit, but what are the main causes of inflammatory bowel disease?
Yeah.
Besides that it can be hereditary, but it's not always.
Right. And I think we just kind of mentioned some of those. Definitely, the diet. So we know that going to an anti-inflammatory diet or a Mediterranean diet can help improve inflammation. There are studies that show that it lowers the CRP. It's a marker of inflammation in the blood. So not only helps with symptoms, but can help. So we know diet plays a big role. Like I said, medications, if you've been exposed to infections and viruses, can all trigger the diagnosis. And it's most commonly diagnosed at a younger age, like from 15 to 35, but can be at any age. And we're seeing a second big bump in elderly patients, 60 to 80.
Wow. Mm-hmm. Wow. So what are the symptoms of Crohn's and ulcerative colitis? So what should we be looking for?
Yes. So most people have probably had some GI symptoms before. I think we'd be lying if we said we hadn't had something like a stomach ache or diarrhea. So ulcerative colitis, we'll start with that one since it involves the colon. And it can be something as simple as a change in bowel movements. You may have an increased number of bowel movements, diarrhea, or some people have constipation, may develop some abdominal pain. You may notice that you're getting up in the middle of the night to have a bowel movement after, not being able to sleep through the night to be able to do that. You may notice some blood in the stool, not just blood on the toilet paper, but blood, passage of clots. And if it becomes more severe, you can develop, like I said, abdominal pain, sometimes fevers, being really fatigued. Now Crohn's, because Crohn's can evolve anywhere in the GI system, depending on the severity and the location, that presentation could be a little trickier to diagnose. The most common location is in the small intestine, the end, called the ileum, that connects right next to the colon. That, and then the ileal and the colon, or the large intestine, are the most common areas. So those presentations can, again, present with some diarrhea, may present with some right-sided abdominal pain, fatigue. But sometimes people have involvement in the upper gut. So you may have a bellyache after eating, nausea, or vomiting. If there's inflammation in the colon, it's similar to ulcerative colitis. So you can have the diarrhea, the bleeding, getting up at night. Now, as I said, Crohn's, not only it can be anywhere in the GI tract, also has different phenotypes. So there's
What's a phenotype?
Yeah, and phenotype is the type of it. So ulcerative colitis is inflammatory. So Crohn's can be inflammatory, but it can also have a component of stricturing, and that means narrowing. So think of it as like a funnel, that the intestine becomes smaller like a funnel. So you can develop pain, throwing up. Sometimes patients, their first presentation is when they go to the hospital with an obstruction or that blockage. There can also be a fistulizing, and a fistula is an abnormal tract. And I tell people sometimes it's like a straw. It can go from the small intestine to another part of the small intestine, or the small intestine to the colon. Sometimes even from the intestines to the bladder or the vagina, or even out to the skin.
Wow.
So, and that can present not only with diarrhea, but then, you're noticing something coming from the skin, drainage and pus.
So this can affect much more. It's not just the digestive system.
Correct. And we speak of a chronic inflammation in the digestive system, but inflammatory bowel disease can affect every system of the body.
Wow,
Every
I didn't
system.
know that.
Yes. Common things are the eyes, your joints, your skin. So going to your eyes, you may develop a red, painful swelling, loss of vision, like uveitis, episcleritis. The skin, we know that conditions like psoriasis and eczema are associated with Crohn's and ulcerative colitis, but sometimes you get these red, painful welts in your shins called erythema nodosum that can be related to the disease.
Wow.
There's conditions you get in your groin called hidradenitis that can be related to the disease. And joint pain is very common. We think of, overuse joints, but you can develop inflammation in your joints called an inflammatory arthropathy, that you're stiff in the morning. You can barely get out of bed, and it's not until you're moving later in the day.
I mean, this really sounds terrible.
but there's hope. We'll talk. There's medicines to treat.
Good.
Right.
Good.
Right.
So are there any other complications of the disease other than what you just mentioned?
The biggest complications I like to tell patients are that it's untreated disease. We know that the disease is chronic inflammation, but we have treatment to control that inflammation. So we're trying to stop the hospitalization, the need for emergency surgery, developing an obstruction, and even uncontrolled disease can even lead to cancer.
Oh, wow. This just gets worse. But I know there's hope. There's hope.
There's hope.
There's hope. There's hope. What can cause or trigger a flare-up?
Well, a flare is ongoing inflammation. So for us, it would be symptoms. So it would be your pain, diarrhea, fatigue. And the biggest trigger for causing a flare is stopping medication. You know, as I said, right, IBD is not a curative. We don't have a cure for it, but we have treatment to put it into remission. And so a lot of times if people are in remission, they feel good. They say, oh, I don't want to take this medicine.
I don't need it anymore.
And it may stop it. So that can cause a flare. Sometimes exposure to other medicines. Sometimes an infection can cause a flare.
Wow. Okay. Well, so how do you go about diagnosing IBD?
So diagnosing takes several steps. And as we said, a lot of people have had GI issues, right? You've probably had a stomach ache or constipation or diarrhea, but these are things that go on, persist. Like I said, waking up at night. So your doctor will usually refer you to a gastroenterologist. That's a specialist in GI. And we do a thorough history and physical because we're looking for all of those extra intestinal, those things like the skin, the joints, in addition to your GI symptoms. We do tests. We start with things looking for anemia, so some blood tests. We look at markers of inflammation. That's a CRP, it's a blood test. We have stool tests that we do called fecal calprotectin that can check for inflammation that you don't see in other diseases. So we start there, and then we may do some imaging. So CT scans, but they're a little more specialized CT scans, like a CT enterography. And that looks at the small intestine in addition to the colon. And what we're looking for is inflammation, inflammatory changes, maybe those narrowing areas that we talked about.
So is that like a colonoscopy plus?
Well, yeah, right. And so you start with the imaging, the CT scan, and then ultimately our gold standard is the endoscopy, right?
Right.
So usually a colonoscopy, and that's where we take that camera that's on the long,
the little tiny, yes, yeah.
And we start at the rectum, go all the way around the colon, and into the end of the small intestine, the ileum. So we're able to look for inflammation, see how severe, and we can take biopsies or pieces. Some patients may need an upper scope. So if they have upper symptoms, we may need to go down the throat into the stomach and small intestine. And then not to scare you, but sometimes, we can reach both areas, but there's a lot of small intestine that we don't normally see with our scope. And sometimes patients need to swallow a little camera called a video capsule endoscopy.
I've heard about these.
And it takes about 8,000 pictures of your small intestine to look for inflammation that, we're not able to reach with our scope.
Wow. They've got everything.
Yes.
They've thought of everything.
So.
Okay. So let's talk about some treatment options. Let's get to the hopeful part.
The hopeful part,
that's
right?
Enough of the downer stuff.
Yes. So, yes, definitely the hope that there is, hope for remission, right?
Because there is hope, right?
Yes, there definitely is hope. And just as complex as the disease is, I like to tell patients it's not just throwing medicine in at a patient. We have our WVU IBD Center, which is a multidisciplinary center because you have a disease that affects every aspect of your life. And you should have all of these specialists helping take care of your disease, with our goal being remission. So we have the gastroenterologist, and we'll treat with medications for our goal to be in remission. But we also have our dietitian because we know that diet is important in treating the disease. We work very closely with our colorectal surgeons because sometimes surgery is necessary and doesn't mean it's a failure, but it is a good option sometimes. We also work closely with our rheumatologist, our dermatologist. And inside our clinic, we do have access to our pharmacist who helps patients with medications so that if we prescribe medications, they don't need to be worried about, can I afford this? How do I take this? And monitoring. And also she works very closely at smoking cessation. So a whole team approach at treatment for the patient.
When you mention remission, I don't think everybody has a clear definition of what exactly remission is. Does that mean if I'm in remission, it's never going to come back again?
That would be great.
That's what it sounds like.
Right. That would be great. And we're getting there. We're getting there. Remission is defined by a few things. First of all, we talk about like our short-term goal. It would be clinical. We want you to feel better. So if you came in with abdominal pain or diarrhea, I'd like that to go away so that you don't have to worry about coming to work. Where are all the clean bathrooms? You'll be able to go to dinner with your friends, things like that. Then we follow up and we make sure that the medicine we have you on is working. So we do additional labs and stool studies and then repeat that colonoscopy to make sure that the disease is under control. A lot of the new treatments, once you're in remission, you can continue and stay in remission. Sometimes there are those flares, or I tell people a minor setback, but it doesn't mean that we're getting back to where we first started.
Okay. And when you say medications, are these mostly pills? Are they injections? Or are they a little bit of everything?
A little bit of everything. We've come a long way. If I can indulge you in a minute just to tell you how far we've come. I get very excited about this.
Please.
That this disease really, when we talk about it, is only about 100 years old. It was first diagnosed or talked about like in 1930s, 1932 by Dr. Crohn, Ginsburg, right? And Oppenheimer. And before that, people would have with the diarrhea, they thought it was an infection or TB of the intestines. And so they first said that this was an entity, but we were really bad at treating it. So patients would get bed rest or surgery. And that didn't go well, right?
No.
And then it wasn't until about 1955 that we had two other doctors, True Love and Witz. They came across and said that prednisone, they found that giving patients prednisone to help the inflammation could put people in remission, up to 40% of patients. And we still follow those rules when patients come in with severe disease to the hospital, especially ulcerative colitis. But we know that that's not a perfect. It comes with a lot of side effects itself, and it's not good long term. And as we learn more, as we talked earlier, that the Crohn's, those inflammatory cells, right? That we're learning more about the immunology. So in the late 1990s, we had our first biologic. It was infliximab. So it revolutionized.
Now, what's a biologic?
Biologics are medicines that are actually stopping that inflammation. So all of those inflammatory cells come and they send off signals called cytokines. And what they're doing is bringing more inflammatory cells to your colon or your small intestine. And basically what these new medicines, biologics or small molecules, basically block that signal and say, you don't really need to be here, and go work on something else that you need to be working on.
Oh, okay.
Yeah.
Are these relatively new, these biologics?
Well, the first biologics was in the late 90s, so 1998. But since that time, we've learned a lot more about the immunology. There's many different cytokines. So we're able to target specific ones. So now there's many different pathways. So we have medicines, instead of just going to get IV medicines, you can have an injection every 8 weeks instead of going to an infusion center. That means giving yourself a little shot at home. And now the newer therapies, even taking a pill once a day.
Wow. And that's really come a long way.
Yes, come a long way. Yes.
Which is why you're so hopeful, right?
Yes, I am. I am hopeful. Yes. And as we learn more about the disease, we're able to tell, we're learning the genetics, which patients might benefit from which medicine, and knowing, there's certain medicines that are better if you have joint symptoms and skin symptoms. So that's why it's really important to get into a gastroenterologist for treatment.
Is there one particular treatment that's like the latest, greatest hope that, that you're most excited about for your patients?
I think the fact that we have many more medicines that we're able to monitor. I say the best medicine for the patient is the one that works. So getting the disease diagnosed early, looking at all of those other cofactors, what your past medical history, what other conditions, finding that right medicine and getting you on that early.
So it doesn't sound like this is like a one-size-fits-all treatment. What works for one person might not work at all for another.
Exactly. Okay. And sometimes the first medicine may not be perfect. We're only human, right?
Sure.
And you may need to be, doesn't mean one and done, that you may need to switch medications at some point in your life. But I emphasize that you'll probably need to be on a medicine for the rest of your life.
So what are the goals of therapy? I imagine it's finding what that combination is that works for you.
Right. And that ultimate goal is remission, right? So we want our patients to not have that inflammation. So once that inflammation is controlled, then they won't have the diarrhea, abdominal pain, or throwing up. Their energy is better. And we can see, their joint pain, things are better. They're able to go to work, go out to dinner with their friends and family. Our goal is for them to have a, long, healthy life.
Wow. Can you talk a little bit about the expertise of the team at the WVU Medicine IBD Center?
Yes. So our team, we're growing. We have 2 gastroenterologists. We have a nurse practitioner, a nurse, a social worker, a pharmacist, all in our clinic. So when patients come in, like I said, you're a whole team approach. You belong to the team, and we want you to get better. We're rooting you on. Then you also have access at the same time that we can get you to see the surgeons if you need, dermatology, rheumatology. We have monthly meetings where we discuss complicated patients with radiologists and pathology. So we're always talking about patients and working together to find, a common treatment for patients that not only what we want, but what the patients want. And we also continue our education. We do training every year, with the latest studies. We have trials of medications here that, if these standard drugs don't work, we can get patients access to other drugs that may help.
Well, that's good to know. That's really good to know. So before we go, I always like to ask, what's the most important thing you want our viewers or listeners to know about IBD, Crohn's, and ulcerative colitis?
That's a great question. I would like people to know that although it is a chronic disease and we don't have a cure yet, right? With the right treatment and the right team, we can get people into remission and they can enjoy life and live a long, healthy life.
So there is reason for hope.
Yes, there is. Definitely, right? Definitely.
So as the number of cases are going up, is the number of remissions going up as well?
Yes, because we're able to get patients on treatments sooner and get them in remission. And the newer medicines, we're able to keep them in remission.
And you know more.
Yes, we do. Definitely.
Well, that's great. Thank you so much for sharing all this information with us.
Thank you for having me.
I think we helped a lot of people today.
Thank you.
Giving hope. That's what we're all about here. We want to give hope.
Yes. Thank you.
Thank you. Well, that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information about this or other conditions, visit WVUmedicine.org. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast or the Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. Hadam-Veverka and everyone at WVU Medicine, thanks for joining us.